The following is an audio documentary, written, produced, and narrated by Arnav, Singh, and Rushil Yerrabelli. Let the dark side of data begin. Artificial intelligence has the potential to revolutionize medicine, transforming everything from how we diagnose diseases to how we monitor and treat patients. But with great power comes great responsibility. We must ensure that algorithms we deploy are transparent, free from bias. The utmost respect for patient privacy and autonomy. Only then can we fully harness the potential of AI to improve healthcare for all.
In 2022, LA-based software startup Regard, formerly known as Health Tensor, broke news after receiving $15.3 million in Series A funding for their artificial intelligence copilot, designed to assist physicians in providing care by automating electronic health records. Regard is not alone. It is the latest in line of many companies, with the integration of machine learning algorithms in hospital systems growing vastly following the COVID-19 pandemic. Since 2019, there's been a sharp increase in healthcare spending on AI/ML, rising from $463 million in 2019 to over $2 billion expected by 2024. With clinical AI applications expected to create up to $150 billion in annual savings by 2026, the use of ML algorithms in predicting patient outcomes and diagnosing diseases is expected to exponentially increase.
Clinical applications of AI offer a wealth of potential benefits, including improved diagnostic accuracy, early detection of diseases, and the estimation of probable outcomes of patient conditions and/or treatments. For example, an AI-based symptom checker had a higher diagnostic accuracy for inflammatory rheumatic disease compared to physicians, 70% versus 54%, based on the top most likely diagnosis. Such advancements have the potential to revolutionize patient care, reduce the burden on healthcare professionals, and lead to improved overall health outcomes.
However, while the potential of improved diagnostics, predictive analytics, and a solution to the post-COVID physician burnout crisis seems promising, there are several underlying concerns that, if unaddressed, could lead to unintended consequences that outweigh the potential benefits. With ML algorithms needing access to high volumes of data, usually obtained through EHR, the question of patient privacy security arises. Furthermore, with ML algorithms requiring training data to enable them to recognize patterns and make predictions, the possibility of ingrained societal biases creeping into algorithms through training data raises the risk of the perpetuation of existing inequalities and inequitable treatment.
Unsupervised learning is a subset of machine learning, which is a subset of AI aiming to identify natural occurring patterns within a dataset. The dataset provided to the algorithm contains unlabeled data with no output values or labels. The algorithm is trained to find structure or patterns in the input data on its own without any human input or pre-existing knowledge of the data. Examples of unsupervised learning in clinical applications include using clustering to identify distinct subtypes of diseases, grouping patients based on their medical history to enable physicians to identify high-risk patients and optimize resources, and employing anomaly detection techniques in medical imaging, such as X-rays or MRIs, by learning the pattern of normal images and using this knowledge to identify deviations in new images.
Unsupervised learning in healthcare is used for a variety of applications to identify patterns in unlabeled datasets. Algorithmically, these approaches are broken up into four main types of algorithms: K-means clustering, hierarchical clustering, principal component analysis, PCA, and factor analysis. K-means clustering and hierarchical clustering partition data into groups based on similarities in the data, whereas PCA and factor analysis are unsupervised dimensionality reduction tools that can simplify and increase the interpretability of high-dimension datasets.
Supervised learning, in contrast, has the goal of predicting outcomes given any input. The dataset provided to the algorithm contains labeled data where each data point is associated with an output value or label. This dataset is then split into two subsets, a training set and a testing set. The algorithm is then trained to recognize patterns in the training data and output the correct value or label. After the algorithm is trained, it is then tested on the testing data to evaluate the algorithm's performance on unseen data and is further used to optimize the algorithm to correctly predict the outcome given any input. Examples of supervised learning algorithms in clinical applications include early diagnosing of diseases based on test results, imaging, and EHR, predicting likely outcomes of diseases/treatments for a given patient based on clinical data, and predicting risk of readmission for patient populations. These applications overall improve patient outcomes and allow for more accurate, personalized treatment plans.
While the integration of machine learning algorithms in healthcare has the potential to revolutionize diagnostics and predictive analytics, it is crucial to first address the concerns surrounding patient privacy, algorithmic biases, and transparency to ensure the safe and equitable application of this technology for the betterment of patient outcomes and healthcare systems. Only if these concerns are addressed can we ensure the successful implementation of machine learning algorithms in clinical applications.
An inherent characteristic of unsupervised machine learning models is the need for large datasets to accurately identify patterns. Larger datasets allow for the increased identification and enhanced quality of clusters through both traditional and modified k-means clustering algorithms, as the maximum intercluster and minimum intracluster distance clusters are produced with increased data points. When intercluster distance is maximized, there is an increased separation between clusters, yielding clusters that are well-defined and distinct from one another, and ensuring that each cluster represents a unique and meaningful grouping of data points. When intra-cluster distance is minimized, data points within the same cluster lie closer together, yielding more compact and cohesive clusters, and ensuring that data points within a cluster are more similar to each other than they are to data points in other clusters.
Furthermore, larger datasets help minimize noise and allow for greater opportunities to increase algorithmic validity by providing greater instances of underlying patterns and subsequently greater opportunities to evaluate its performance against different subsets of data. A similar trend is true for supervised learning algorithms, which also require large datasets to accurately make predictions. Datasets provided to supervised learning models commonly undergo a test-train split into training and testing data. In such cases, there is a risk of overfitting, which occurs when a model learns to perform very well on the training data but cannot generalize predictions on unseen data. With a small dataset, the model may simply learn to memorize the training data rather than capture the underlying patterns that govern the relationship. A larger dataset helps mitigate overfitting, providing more examples for the model to learn from, fully allowing it to capture the true underlying patterns.
Large datasets, essential for the effectiveness of machine learning algorithms, raise significant concerns about data privacy. Machine learning algorithms require vast amounts of sensitive health information, often obtained from EHRs, which contain sensitive patient data such as demographics, medical history, imaging, and lab test results. For example, medical AI startup Regard, which has diagnosed 1.2 million patients to date, accomplished such a feat through a direct partnership with EHR providers Epic and Cerner, which together encompass 114,000 distinctive ambulatory healthcare providers as of 2015, the most out of any two EHR vendors on the market. Consequently, a substantial amounts of training data are collected from various sources like medical and insurance records, pharmaceutical data, genetic data, and social media. The risk of re-identification becomes increasingly evident.
Although the occurrence of such an event on a large scale might appear implausible, patient data breaches have taken place on considerable scales, with current de-identification techniques proving weak. In 1997, Massachusetts GIC released anonymized healthcare records of state employees for research purposes, assured by Massachusetts Governor Bill Weld that their data had been anonymized. However, for just $20, then MIT computer science graduate LaTanya Sweeney purchased a roll of Cambridge voter registration records, and by linking the two datasets, was able to re-identify the Massachusetts governor's health records, along with other state employees. By 2013, Sweeney, now the director of the Data Privacy Lab at Harvard, estimated that she could identify up to 87% of the US population using just zip codes, birth dates, and gender, highlighting vulnerabilities in public patient datasets. These assertions are further supported by a joint study conducted in 2019 by the Imperial College of London and the ICT Institute in Belgium. Using publicly available anonymized demographic data from the US Census Bureau, the researchers designed a generative algorithm that uniquely identified 99.98% of the US population's patient data, demonstrating the prevalence of privacy threats.
Inherent vulnerabilities in machine learning algorithms bring forth the issue of informed patient consent concerning autonomy. Patient records are often made public for collaborative research purposes, either with consent or waivers. However, patients may not grasp the full extent of their data usage. Consider the ongoing study by Yerrabelli and Singh, analyzing single-cell RNA sequencing biopsies from glioblastoma multiforme in 29 patients. Patients consented to have their brain tissue biopsies sequenced and the results published. However, to develop a novel machine learning algorithm for accurately predicting glioma progression into glioblastoma, the researchers employed several unsupervised learning techniques on the single-cell dataset, ultimately divulging more information than the patients originally agreed to provide through multifactorial gene expression analysis. By constructing a supervised learning algorithm for precise predictions, the researchers generated plots correlating clusters with varying gene expression levels for each patient. This additional analysis might have unintentionally disclosed sensitive genomic data about the patients, reflecting a prevalent trend in research. For instance, the Personal Genome Project aimed to establish a public dataset of genomic, environmental, and trait data to enhance personalized medicine. Over time, genomic data was connected to family genealogy and public datasets, such as Ancestry.com, enabling researchers from the Whitehead Institute for Biomedical Research to eventually re-identify anonymous male participant names, thus jeopardizing the privacy of current de-identified public datasets.
Consequences of patient data breaches are multifaceted and have the potential to create severe consequences, encompassing medical identity theft, insurance fraud, loss of personal privacy, and eroding trust in healthcare systems. For instance, the 2019 fifth annual study on medical identity theft reported 2.3 million victims, with an average out-of-pocket cost of $13,500 per victim to resolve the fallout. Furthermore, the FBI estimates that healthcare fraud costs range between $68 and $300 billion annually, representing 3 to 10% of yearly healthcare expenditure. Data breaches in patient data can lead to severe consequences for both patients and providers, including discrimination and stigmatization of patients whose confidential medical records are made public, and large-scale financial and legal burdens on healthcare institutions. It is crucial to address privacy concerns when using machine learning algorithms in healthcare to mitigate these risks and prevent the erosion of trust between patient and provider.
Active safeguards in place designed to protect patient data privacy include the Health Insurance Portability and Accountability Act, HIPAA, in the United States. HIPAA has two primary components, a privacy rule and a security rule. These components require patient consent before disclosing any personal health information and mandate healthcare systems and businesses to implement appropriate safeguards. Under HIPAA, 18 identifying elements such as name, address, birth date, and social security number must be either removed or de-identified before publicly publishing patient datasets for research purposes. However, there remain vulnerabilities in the US legislature. Despite the existence of numerous measures to safeguard patient privacy before datasets are made public, there is a concerning absence of regulations governing the management of patient data afterward. In addressing this issue, policymakers can draw inspiration from European Union legislation. The EU's General Data Protection Regulation requires companies to limit data collection to parameters that are strictly necessary and imposes time limits on access to patient data. While limiting access to parameters may slightly diminish the effectiveness of unsupervised machine learning algorithms due to smaller datasets, it would significantly enhance patient data protection.
Historical biases in healthcare, including the lack of racial and gender diversity in clinical trials and medical research, pose a potential threat to the effectiveness of machine learning algorithms, raising a justice argument. Ensuring that datasets provided to ML algorithms are not only large, but also heterogeneous is crucial for achieving optimal performance for all patients and preventing the exacerbation of existing healthcare disparities. Diverse data reduces noise by offering more examples of the true underlying patterns, allowing unsupervised learning algorithms to make better generalizations and produce more accurate clusterings. When diversity is absent in data, it can lead to misclustering. For example, the PAM50 gene signature classification system used for identifying breast cancer subtypes demonstrated a 43.5% misclassification rate in Black women, over twice the rate of white women.
Diversity in data also improves the quality of training data and provides more label testing data, improving the outcomes of supervised learning models. Specifically, this helps reduce the risk of overfitting and the long tail problem. Overfitting occurs when SL algorithms capture noise instead of underlying patterns, leading to poor predictions of unseen data. For instance, the Framingham Heart Study cardiovascular risk score was widely used in medical practice for decades, overestimating the 10-year risk of coronary heart disease by 52% in Black men and 8% in Black women, compared to the actual observed event rates. Because the training data consisted predominantly of white participants, reflecting the demographics of Framingham, Massachusetts, the SL algorithm was mostly trained to predict CHD risk in whites. This led to exceptionally poor predictions for cases not including in the training set, such as Black patients. Patients from minority backgrounds may be unaware of the potential implications when consenting to the use of algorithms in the medical decision-making process. Unbeknownst to them, they could be consenting to the use of inherently biased algorithms, which might result in misdiagnosis, inadequate treatment plans, or poorer health outcomes, potentially exacerbating existing health disparities. For example, patients admitted to the University of Michigan and University of San Francisco Hospital ICUs consented to the use of pulse oximeters to measure blood oxygen saturation by emitting light onto the patient's skin. Ultimately, the algorithm employed in the pulse oximeters demonstrated a threefold higher risk of undetected hypoxia in Black patients compared to white patients. In minority populations where low trust in healthcare systems is already a significant barrier, such occurrences could further erode trust.
Potential approaches for mitigating the extent of bias in ML algorithms involve regularization techniques for models. Regularization reduces the complexity of models by assigning a penalty to the model's loss function, the difference between the predicted and actual output, discouraging the model from assigning too much weight to any single feature or specific pattern, and limiting the effects of overfitting. While reducing complexity prevents capturing extraneous noise, the ultimate solution to mentioned problems is increasing the diversity of training data for ML algorithms. Other approaches, such as the upscaling of the significant value of data from minority populations, will not directly solve either overfitting or long-tail problem issues, as imbalances in the distribution of data and lack of underlying patterns for the algorithm to generalize upon would still remain. Incorporating more diverse data, including data from minority patients, can improve the generalization capabilities of ML algorithms to different patient groups, ultimately resulting in better performance and more equitable predictions.
The integration of machine learning algorithms in healthcare holds immense potential for improving diagnostic accuracy, treatment efficacy, and overall patient care. However, current challenges including the protection of patient data privacy and biases in the clinical use of machine learning algorithms highlight the importance of addressing the ethical and practical implications of this technology. To ensure patient privacy is protected, it is recommended that regulatory committees on the use of AI and machine learning in healthcare draw inspiration from the EU's General Data Protection Regulation. To ensure equitable healthcare outcomes, it is crucial to increase the diversity of training data to counteract historical biases in healthcare from creeping into machine learning models. Moreover, fostering transparency and the informed consent in the use of machine learning algorithms will help build trust between healthcare providers and patients, particularly among minority populations. By addressing these concerns and implementing the suggested solutions, the full potential of machine learning in healthcare can be harnessed, paving the way for a more protected, accurate, and equitable healthcare system for all.